Welcome to the Kirby Institute's regular seminar. For those who don't know me, is there anyone? Is there anyone? I'm sorry. What's that? Is there anyone in this small universe of ours that doesn't know me? Well, I have been working longer than anybody else. So if you don't know me, it's time you did. Yeah, so John Keldor from the Kirby Institute Global Health Program. And I start off, as we always do, by acknowledging the traditional owners, the medical people of the Eora Nation, and acknowledge any Aboriginal and Torres Strait Islander people who are with us today. I have a special seminar today, but it's the occasion we have actually a visit from a very substantial delegation from a very substantial organization. The Clinton Health Access Initiative, I think, would be known to all of you. It's a crucial part of, has become a crucial part of the global health architecture, and I think in current times, as thanks for the compliment, Greg, of what I've just has become more crucial than ever, as that we work with organisations such as the Clinton Health Access Initiative in all of our efforts in global health. We actually have a very senior delegation from CHI visiting us today, and we have a number of meetings this afternoon on specific topics. Among others, we have Chief Operating Officer Josh Chu and the Chief Scientific Officer Herb Harwell, sorry, who I've just met. I'd actually met 20 years ago, apparently. Also, some old friends who've worked with us for a long time. I just acknowledge Dr. Kiramat, who's somewhere, who we met 20 years ago, collaborated with us, and represents CHI from Papua New Guinea. And Garrett Young, who's worked very closely with us on projects on laboratory strengthening based in Laos. And of course, Pravina, where's Pravina, who works for CHI and now works for CHI, but was with us for a few years before heading off to Laos. But the speaker today is Dr. Justin Cohen, who's Vice President for Malaria and Neglected Tropical Diseases at CHI. I guess you're based in New York, is that correct? Yeah. So Justin has collaborated in over 30 countries to strengthening malaria control and also moving into the control of neglected tropical diseases, which is an area of particular interest for the Kirby Institute. And he's has a doctorate from the University of Michigan and has a number of publications in the area of malaria elimination, as well as health system strengthening, a number of other related areas. So we look forward to hearing what he has to say and look forward to this afternoon's meetings with the CHI team. And thanks very much to Garrett and Pravina for having organised this. Probably as everyone, our director, Tony Kelleher, is actually on leave this week and sends his very sincere apologies.
Thank you so much. And thank you for the invitation to speak today. This is my first time in Sydney. And so I would like to take the opportunity to acknowledge the Badjidal people of the Eora Nation and pay my respects to their elders past and present. I hope will not be my last time doing so. But I'm excited to talk to you about the work we've been doing in malaria elimination in the Asia Pacific. And I'll be talking mostly about the Mekong subregion, which is the place where we've been working the longest and where we have, I really think, the most lessons learned to share as we think both at CHI and broadly about how we can bring these sorts of successes to neglected tropical diseases in this region as well as elsewhere where we work. And it sounds like some of you are familiar with CHI from over the years, but for those who are not, I'll start with just a little bit of background on our organization so you know who we are and kind of to contextualize the work that we're doing in the region. So CHI's mission is to save lives. We're an international public health organization, and we work, I think, really at two levels. The level which I've always been most engaged as an epidemiologist is our embedded in-country support. So we're in 36 countries right now where we have staff who are there on a daily basis helping governments to achieve the goals they've set for themselves within public health. I was just in PNG last week with Dr. Kiramat, and our team there has an office in the National Health Organization there. Our desks are on the same floor, so we can be there as a day-to-day partner, helping to troubleshoot, helping to deal with the issues that come up. We're not as technical as our partners at WHO. We try to be really the operational partner who can help to get stuff done. And I'll share how that's played out in elimination. We also work globally. We have really strong partnerships with suppliers, with WHO, with other international organizations. And I think it's those two layers that make the organization powerful. The fact that we can be a representative for the national malaria control programs on the world stage to make sure that they're able to access the tools that they need at affordable prices, and we're able to share information and improve communications around the world. Most of our staff are local nationals working in their home countries, about 1,700 people, the great majority in the endemic countries where we work. So our strategy is to play 4 key roles, and I'll just briefly kind of share what we mean by each of these before I tell you a bit more about elimination specifically. And I'll couch these in terms of some of the projects I've been involved with. So first, that second role that I shared, market shaping. It's about creating affordable, sustainable marketplaces for health commodities and services to enhance equitable access. What that means, for example, we did do price negotiations on some of the next generation bed nets, but most recently what we're trying to do is to work with the governments we collaborate with and the donors to try to drive the market of bed nets towards products that last longer. Right? A long-lasting insecticidal net is supposed to last about 3 years after you distribute it, but we're finding probably the median is more like 1.5 years, right? But there's huge variance, and there are products out there that last a lot longer, and yet right now, donors tend to buy nets based on price solely, right? And so we're trying to help think through how do we drive the market towards more cost-effective nets and not just the cheapest nets. Another example, which would love to come back and talk more about, is Wolbachia, an Australian export. We're working on the technology that was pioneered at Monash University, our World Mosquito Program. And what we're trying to do is to help the academics, the suppliers working in that space to figure out how do we bring this globally much more quickly than might happen otherwise? How do we think about the price? How do we think about the accessibility of supply, regional manufacturing, right? So with a lot of new tools, we can play that kind of role, helping to think about the supply ecosystem and how we can make sure that countries are able to access the products that are going to be life-saving or public health burden reducing as quickly as possible. The next 2 I'll share are related to our in-country work, right? So we're a strategic partner to governments. That can mean a lot of different things. We work at national level. We also often have embedded staff at subnational level. So we're not just sitting in the capital, but we're out there trying to help program managers who are really doing the day-to-day work on health systems. And of course, what this has meant lately is a lot of work around resource allocation. We do have budgets that are going to be shrinking. We can be pretty confident, I think, that Global Fund is going to be revisiting some of its budgets for next year. And so we're in a difficult position where we need to help malaria programs and other health programs figure out how can they use the resources that they have as efficiently as they possibly can to drive down burden. Does not mean we shouldn't be advocating for more money. We 100% should be, but we have a pretty rich toolbox in malaria. How do we choose which tool to use? Is it chemoprevention for this district? Should we be doing the vaccine? Should we be using bed nets? We have to use evidence to make those decisions. In the last Global Fund round, we touched about $1.3 billion in Global Fund funding across quite a few countries. So we're doing this in many different places. And here's an example of what that might look like. So this is an actual country in West Africa. And on the left is the national strategic plan that we helped the country devise, right? It's an evidence-based plan, but it's removed from the price tag of how much money do you actually have available. It's what do you want to do in the country in order to achieve the strategic goals you've set, which are, pretty transformative, drive down malaria kinds of goals. The price tag on this is 500 million euro. The allocation from the Global Fund, the single biggest donor for malaria, was 159 million euro, right? And so what we need to do is help countries go through an evidence-based process. We use mathematical modeling, we use geospatial analysis, lots of things that I'll show you in the elimination context to try to whittle down that big strategy to here are the priorities that we're actually going to get funded. Third, we're an operational partner. So once that grant is funded, how do we help countries actually implement that plan as efficiently and effectively as possible? An example might be, again, new tool introduction. So these next generation bed nets that I referred to, there's a lot of work that involves a new product. Even if it's a class that you've been using, you need to think through your procurement. How many of these do we need to buy? Your warehousing, potentially if it's a new drug, the training, the guidelines, the M&E, right? And so we can help to be there as an operational partner to work through that process, scale these products up as quickly as possible. And the graph I'm showing you is just a comparison we did of the fraction of bed nets being procured in Africa by which are these next generation products that we believe are almost across the boards the more appropriate tool to be using at this point. And you can see that in the CHI supported countries, we're able to catalyze this uptake more quickly. And then, probably very familiar sorts of figures, but the actual deployment, we do a lot of campaigns in public health, right? And so helping governments to think through how do they manage those campaigns. And I'll share a little bit more later in the talk, but thinking through potential digital tools, trying not to create that universe of different fragmented tools, but trying to have government own one system that really can work across many different health programs that allows them to track where did we actually put these commodities, what are they actually achieving, so that we use our resources as efficiently as we can. And where this all comes together in the middle, ecosystem catalyst, maybe a little buzzwordy, but basically what we mean is trying to pursue big agendas, whether those are regional agendas, global agendas. And for me, malaria elimination has been the one where we've tried to play that catalytic role. And so that's what I'll spend most of the rest of the time talking about. I've been working in malaria elimination pretty much my whole career, which I've spent entirely at CHI. I came out of my PhD as a technical advisor and never left, in part because I've gotten to work on really exciting things like malaria elimination, collaborating with WHO on how do you actually assess whether a country is technically able to do it. Because not all countries probably are there with the tools that we have today. What would be required operationally? What does a budget look like for an elimination plan? And we're not talking about we're going to eliminate in 3 years kind of plan, but a serious one that we believe can get the job done. I've helped WHO to integrate mathematical modeling into their guidelines around elimination. So we're able to now bring that kind of theoretical evidence to bear on elimination. And we've helped very pragmatically to build funding mechanisms. For example, some cash on delivery funding mechanisms where countries receive rewards if they meet certain reduction targets, working with development banks, including the Asian Development Bank and the American Development Bank. So this is a success story, the Eastern Mekong. I'm going, if you've noticed, from Asia Pacific to Mekong to Eastern Mekong in quick succession. This is our biggest success story I think we have in malaria today, so we will brag about it. The Mekong, of course, also includes Myanmar, and I'll show you some data from there later. It is not going great, and I think it is important to recognize that we shouldn't only talk about the success stories. We also have to talk about the places where what we're doing is not going as well as we would hope. But I think Cambodia, Laos, and Vietnam all deserve incredible congratulations for this achievement. It's a 99% reduction since we started really supporting elimination activities in 2014. I think it's a historic change. You can see the stack bar was around 100,000 cases in 2014. These are confirmed cases, and we were talking in the car over. I'll show some data later. But if you actually look at the reported cases, which includes fevers that were just clinically diagnosed rather than with confirmatory diagnostics, that number would be much, much larger. Let me just give you a little context. Many of you probably know the story of malaria in the region, but why did we start pursuing elimination? The answer was drug resistance, that we saw the beginnings of artemisinin resistance. The main drug we use for falciparum malaria in particular is an ACT, an artemisinin combination therapy. That's an artemisinin-based drug combined with a partner drug. This was considered to be a global emergency when we started to see the delayed clearance of artemisinin-based drugs in the region. Less because we felt that there was immediate ramifications for mortality in this region where it's always been fairly low, but more the fear that these strains would spread to Africa and we would lose really the only drugs that we have to fight malaria. It would be devastating. So what was immediately catalyzed was a response regionally coordinated by WHO. And at first it was about containment, but very quickly pivoted to the idea of eliminating malaria altogether. And Dr. Chris Plow, American professor, wrote a nice op-ed about that change. He said, we now have clear evidence that multi-drug resistance has spread crossing national borders. And even worse, we're seeing new resistant strains are popping up in essentially a game of whack-a-mole. And I don't know how well whack-a-mole translates internationally, but you have the mallet and you have to beat down the moles to play whack-a-mole. Okay. Not every country has whack-a-mole, I think. They maybe call it something else. Instead, we should focus on a more ambitious strategy to eliminate malaria from the Mekong altogether. This will be difficult because the areas with highest malaria tend to be poor, rural, and undeveloped. But with coordination, hard work, and proper funding, we can achieve our goal. And I think fairly prophetic. And one thing to note, just the kind of caveat on this, is that we now do have the appearance of resistance in Africa, and it did pop up in the whack-a-mole approach. It did not spread from the Mekong. And I think that's very likely that it didn't spread because of these efforts. So we bought ourselves some time, but now we are having to confront some of the same issues in sub-Saharan Africa, where the great majority of malaria mortality and morbidity are, and likely we're going to have to do it with less funding. That is a lecture for another day, however. So Chai came in. We delayed starting in the region for a long time. On malaria elimination specifically. And that was because there were so many partners doing so many activities with so much money coming from Southern Africa, where we had been thinking about elimination, to the Mekong. It was surprising how well resourced the programs were, thanks to the incredible worry about the resistant strain spreading. So when we started thinking, now, how can we help this process? We didn't come up with a technical answer. It wasn't some new strategy for elimination. It was organization. We came in to help governments coordinate their partners and try to align all of that money behind strategies that were going to work. It was essentially a secretarial role. We sat with the program and said, do you have a plan? How do these different partner activities fit with your plan? Is this research that's being done supportive of your plan? And so, this is a work plan. We have strategies, activities, sub-activities. We say who is doing what, when are they going to do it? This is Cambodia's. It was compiled into the first malaria elimination action plan, which laid out the vision for how the country could get to elimination. By 2020, admittedly, we did not achieve that, but we're not too far off, I'm glad to say. And the power of having this plan is that it allowed the government to really take ownership of the program and to take ownership of all of the donor funding coming in a way that wasn't possible when different partners were just doing different things. We started to see partners coming together at meetings and basically aligning their efforts in a common direction. And if you want to eliminate disease, you can't have money working at cross purposes. You really have to figure out a vision and coordinate against it with everyone rowing in the same direction. And this was reflecting on World Malaria Day, just really echoes the successful smallpox eradication program. And there are many differences between smallpox eradication and malaria elimination, but I think it's helpful to think about some of the similarities. And so this was a quote from Bill Foege, one of the architects of the strategy that they ended up deploying that was very surveillance-based. And he said that the real problems of the eradication program were developing routines, documenting the routines, hiring, supervising, motivating, evaluating. And what you needed to do that were managers, administrators, logistics experts, people who knew how to solve problems and get things done. The program wouldn't fail for lack of scientists, but it could fail even with the best strategy if we didn't get the best managers. So we were coming in to try to bring that kind of attitude to programs, right? That's not just research the resistance, let's figure out how we manage a plan that's going to actually get the job done. That said, I'm an epidemiologist. I do enjoy the theoretical underpinnings of elimination. And so just to get us all on the same page, right? What are we trying to do in the region? We're trying to create the ecological conditions by which malaria goes down over time, right? Mathematically, it's the reproductive number under control. If that number is greater than 1, then we see each infection tends to lead to more than 1 onwards infections and malaria grows, right? An epidemic. So we want to get RC less than 1 such that each infection is less likely to spread than to be cured or to die out, right? So that's what we're trying to achieve. But the dying out can happen over a really long period of time. And so we started by thinking, how long is this really going to take? Because if you make commitments, and that action framework that I showed you did say we get it done by 2020, there's serious risk to your donor funding when you say, well, actually, we're going to need till 2025. But then, well, actually, it's 2030 now. And I think elimination in particular, it's pretty easy to measure whether you've done it or not, right? And so we need to be honest about how long these things take. This is a review article I worked on recently where we tried to find all of the successful examples where countries had actually reached 0 cases, right? And I found 45 of these kinds of countries where this is the year they achieved 0. And then we compiled their case history, how many cases they had per year, going back as long as we could go. And this is kind of the aggregate across all of these 45 timelines. And what you can kind of see is this common pattern that it's not true everywhere, but it tends to be pretty characteristic of how elimination works. And you can see over decades, we have kind of a slow decline, right? I should say this is on the log scale, right? And so if you graph cases on a log scale, a straight line is basically your rate of change, right? So it's sort of a proxy for that RC measure. If it's going down, that means we're seeing a consistent rate of fall in transmission. So this kind of slow decline, I would hazard, is due to background factors that are not really in the control of the malaria program, right? The beauty of working on malaria is that you have your wind at the sails from a lot of things that are changing globally. If people urbanize, if you move to the cities, you tend to have less malaria because malaria is a more rural disease. If people live in higher quality housing as they get more money, they're less likely to get bit by mosquitoes, right? And so we have a lot of kind of ecological and environmental things. Deforestation in the region has been working in our favor. It's not our preferred strategy for getting rid of malaria, but given that the mosquitoes that transmit malaria in Southeast Asia live in the forest, if you chop down all the forests, you get less malaria. It would be the opposite in Africa. But what you can see is a statistical breakpoint, right? And we did testing on these time series and showed that in almost every one, you have this statistical change. And that change tends to happen about 12 years out from elimination, right? And that change, I think we didn't analyze it rigorously, but it's basically associated with when you start doing the things that really drive down transmission. And what are those things? Well, I mean, excuse my cartoon, but if you have someone who's infected, they're going to remain infected for quite some period of time unless they get cured by drugs, right? And during that time of infection, they can get bit by mosquitoes and lead to onwards transmission. And each of those infections are going to then be infected for that kind of same average period of time until they're cured and they can transmit and so on. And those are our dynamics of transmission. So what can we do? Obviously, the first thing we probably think of for malaria or other vector-borne diseases is we kill mosquitoes, right? And if we kill mosquitoes, we prevent some of that onwards transmission. But alternatively, we could shorten the duration of infection, right? And if we shorten the duration of infection, there's simply less time for the individual to be bit and to have onwards transmission. The best thing we can do is, of course, both at the same time. We get this multiplicative effect, and now we're driving our reproductive number down. And we don't have to know exactly how low we have to get it, but the goal is to get it as low as we can, such that over time, again, and time might be about 12 years, we're driving malaria down. So the two arms of our elimination program, and really our control programs in Africa too, there's no fundamental difference here, is on the one hand, we're trying to shorten that average duration of infection by getting people to get diagnosed and treated as fast as they can when they get suspected malaria symptoms. So improving high quality diagnosis and treatment. We should be pragmatic about that. It's definitely one of our lessons. Public health facilities are good. We'd like people to see doctors, but if people are self-treating at the private sector, let's make sure that there's good quality treatment available there. And there was some private sector treatment when we started. It was largely banned, at least in Cambodia. And so now we don't have great visibility into what's going on in that sector. If we can extend case management into the community, even better, because that'll shorten the time between somebody getting infected and ultimately getting cured. On the other hand, we need to kill some mosquitoes, or at least prevent them from biting people, right? Which is, bed nets do a little bit of both, but we can consider other prevention too. Historically, there was a lot of work on larviciding, draining swamps, big-scale environmental changes. Most of those things are not used today as tools, but we do have other new tools that are coming, including the malaria vaccine, which I won't talk about today, but you may have heard about. And we have new tools like spatial emanators, which you hang up on the wall, and they kind of release repellent that makes it unlikely that the mosquito will bite you. So that's what we're trying to achieve, all right? Now, I'm going to go back to my friend Bill Foege for a moment, if you'll indulge me. My North Star in how we do this and why I think the Mekong has been successful is surveillance. The fact is, if we just try to use these tools indiscriminately, the region is too big, too heterogeneous, and we will not be successful in putting the energy that we need into the places that matter most. And this is a lesson that I heard from Dr. Foege. He published in 1975 this episode in Nigeria. And you may know the story already, but it's a lovely story. Basically, there was an outbreak of polio of smallpox happening in Nigeria in 1968. And they did not get their vaccine shipments in. So they had wildly insufficient vaccine to pursue their strategy, which at the time was universal vaccination. You got to get out there and vaccinate everybody. So they either could have sat at home and said, well, we clearly can't do it, so let's just not try. Or they could think creatively and come up with a new plan. And so what did they do? They used all of the data that they have about where they'd been observing cases, and they tried to hyper target the people who truly needed vaccination the most. And that plan goes by a lot of different names: surveillance, containment, ring vaccination. It became the core for the rest of the global campaign. It was incredibly successful. A slightly lesser known story is that of rinderpest eradication. Rinderpest, the only other pathogen we've ever eradicated globally. It's a cattle disease. Probably, according to some, the boils that are in the 10 the plagues in the Old Testament. I'm not a historian. I will not take a position on this. But the story of rinderpest, this is a paper by Jeffrey Marner in Science, was that in Ethiopia, they were vaccinating over 20 million cattle annually, and yet not achieving their goal. And that was in part because even though that's pretty good coverage nationally, they were missing the places that mattered most. So they basically started paying herdsmen to report where you actually found rinderpest, and they vaccinated fewer than 3 million cattle in the places that actually mattered, and they saw it go away in a couple of years, right? I tell you these stories to emphasize the point of surveillance. Malaria is not a vaccine preventable disease at this point. We do have a vaccine. It's not going to prevent all of our infections. It's not a simple virus. It's much more complicated. But for me, that doesn't mean that these stories are irrelevant. It means that we need to do this even more if we're going to be successful. And I think exactly the same parallels seem to be true for the neglected tropical diseases. I'll try to show you briefly at the end a couple experiences that we've had recently in the NTD world. But there we are doing mass drug administration approaches that I think are very analogous to mass vaccine approaches. And if we can't figure out how to really target our efforts, we're simply not going to spend the time on the places that matter most. So if we take these two branches of what we need to do to achieve elimination, we want to build them on a foundation of, first, really powerful integrated information systems that can provide the information we need, paired with really strong routine data analysis and use, so that we're figuring out what is actually going on and we are troubleshooting to always do better. And because I work for CHAI, I will again reiterate that I believe the right way to do all of this is through governmental health programs. That doesn't mean the government is personally running everything. They might outsource supply chain or other aspects of the program, but we shouldn't be coming in as CHAI and trying to build some new surveillance system or some fragmented system, especially in a time of resource constraints. We have to figure out, how do we build this capacity in country to run these programs and own these programs? So let me walk through a few examples now specifically of how this has gone in the Mekong. There's a ton we could talk about, so I will be a little bit selective. But the first one is the surveillance system itself. And there's some really cool work that's been done in many countries, but I wanted to share this one, which will be an example from Laos, but I think relevant most everywhere we worked. And that's just the core infrastructure of geospatial information that we use to make these decisions about where do we go or how are our tools working, right? And no surprise, but each of the different systems that we work on have different geospatial information that they need, right? If you're thinking about case data that's coming from health facilities, it would be nice to know where those health facilities are, right? Or maybe case data are aggregated at village level or district level. Well, do we have a map of those? Can we link our case data to where those cases are actually happening? If we're thinking about our stock, our facilities stocked with drugs, again, we need to know where those facilities are, but we also need to know where the warehouses are so we can figure out what an optimal distribution plan is. We might also need to know where our community health workers are, since we're trying to make sure they have rapid tests and drugs in stock. Similarly, with other health workers, if we want to put a community health worker into a specific village, do we know where that village is? And how far is it from a health facility? And intervention data, of course, if you go out and you do a BedNet campaign or a mass drug administration campaign, who received those services? And was it the entire population? What actual coverage do we achieve? We need really good denominators to answer those questions. The challenge, and I'm sure many of you have experienced these challenges, is that data sets aren't linked. Even if we have a reasonably accurate set of this information, and we shouldn't take that as a given, we have to be able to integrate information, right? So on the one hand, we might have a list of our hospitals and our health facilities, and they come with a certain number of cases. Then we have some villages where we have a certain number of people, and maybe we gave out a certain number of bed nets. I remember trying to do an analysis of indoor residual spraying impact in one of the countries we supported, and that was done at district level. So we had these districts receive this much spraying, and then we had these health facilities have reported this much malaria, but nobody could really link the two things together, which made a very simple analysis incredibly frustrating. And then you can think about the same for your stock data. The kicker for anyone who's ever worked with data is that you have wildly different information in different lists that are very hard to triangulate. I do not speak Lao, but the Lao language provides an additional wrinkle. It's a beautiful, beautiful characters. But if you have English characters, Lao characters, abbreviations, and then different IDs used perhaps by different programs, maybe the NTD program calls the health facility one thing and the malaria program calls it something else, you are creating an awful lot of work for yourself. And every person that wants to do an analysis is going to have to re-clean all of this information over and over again. And finally, the geographic component, I don't know if you can see, but these are houses here. And this village is sort of split in two, and it falls on two sides of an administrative line. The people in the village may consider themselves to be one village, but now we've put it in entirely different districts. So figuring out kind of a common vision for how we want to deal with geographic data are the key. So we spent quite a lot of time on this. And the first thing is actually building the digital infrastructure in the information system so that we have common IDs for every place, common spellings, and we are able to link these things together. So here now in Lao, we have an official government entity that is responsible for managing these lists. It's not the NTD program separate from the malaria program, separate from the Statistics Bureau, all giving you different lists of health facilities. There's a single list, and everyone agrees to use that list going forward and to feed any updates into that same list. So that makes life a lot easier. But it also can be pretty transformative when you start getting this geographic data on a map accurately. And I found this example particularly powerful. When we started in Lao, the health facilities were not very well mapped. And the top right figure is sort of the locations that these health facilities were putatively in. And so over time, we work with the program to get more accurate coordinates for all the health facilities and then to put that into that official system. And so this was a series, sometimes it was surveys, but sometimes it was provincial health officers just going out, and when they were doing supervision, they would take a location and other kinds of ad hoc data collection. And so over time, we built up this database of every facility. We can put it on the map. And it has huge ramifications, as you'd expect, right? If we were trying to do an analysis of where do we put a community health worker, and we want to say they should be in any village that has a lot of malaria and is at least 30 minutes away from a health facility, when we use the inaccurate analysis, the inaccurate coordinates, we end up with about 236,000 people in need of that. But in fact, sorry, the reverse, 236,000 people who are not in need of a community health worker, and it goes up by 70,000 when we have the more accurate coordinates. So if we're working with bad data, we simply can't make good decisions about our resources, right? And we're going to waste an awful lot of time and money on distributing products or placing workers or other kind of financial investments in the places where they're not going to necessarily have the most impact. So let me talk more about community health workers, because now we have this information infrastructure, right? So now we want to get to our two big things that we're trying to do. That's reduce the burden, the infectious duration by good quality case management. And then later we'll talk a little bit about vector control. So here's an example from Cambodia. And they call the community health workers their village malaria workers. They are malaria specific workers. And this graph is showing the total number of tests done in the country, with the yellow orange part, the tests that are done at a health facility, and the blue, this community health worker program. And the dark color is the positive tests, just so you can kind of track how we're doing against malaria over time. So when we really started supporting the program in 2014, this program existed already. It had been a big initiative of a lot of donors and partners in the government to expand village malaria workers to 1,500 plus villages in 17 provinces. And you can see from the graph, they're a really important channel by which people get diagnosed and treated. They can provide curative treatment in Cambodia by policy. And so about a third of all of the malaria was being picked up in this way. Now, what happened shortly after we began pursuing elimination as the official regional strategy was a crisis with the Global Fund. Some of you may be familiar. You can Google it if you're not. But there were financial irregularities that led to disruption of the Global Fund grant. And when it was restarted, the agreement was there can be no cash paid for any of the things on the Global Fund grant. And that, from a financial management perspective, makes a ton of sense. It would probably make a lot of lives easier, except that the Village Malaria Worker Program is a cash-based program. These workers are paid to do their jobs, and they are paid in cash. Cambodia did not have a robust mobile money type of system. And so there was no immediate solution for how can we keep paying these workers. And without payment, as you would expect, they stopped working. And so by 2016, for all intents and purposes, that network was gone. So we helped the Cambodia government basically improve mobile money in order to allow this cadre to get paid. This involves a lot of work, which I don't have time to show you, but mapping all of the kiosks across the country, working with the mobile money provider in order to expand, a real kind of market side effort in the private sector in order to provide the infrastructure that was needed to get these workers money. And so over a couple of years, we got back to paying all of our village malaria workers on time, and you can see the big resurgence in their testing. And from there, we now had a fully functional system. We were working hand in hand with the government to support this network. And so we said, if we want to eliminate, we got to take this thing even bigger. So the government expanded the network. We did this sort of analysis. I'll talk more about our risk mapping in a second, but geographic overlay of who is furthest from a health facility, where are the most people, who's at highest risk, in order to help place these workers in optimal locations. And you can see just the massive increase in testing that's happened across the country, almost entirely driven by the Village Malaria Worker Program. And I think fully probably causally related to the reductions in malaria that you can see, where today positivity is just a sliver, and there has not been a falciparum case in Cambodia since last January that was locally acquired. Two lessons here, I guess, when I think about what I can tell other programs, whether NTD or malaria. I mean, certainly for the one, the importance of case management, but that's no surprise. I think the other one is just an elimination program, we have to get creative, right? Like our smallpox people thinking about new ways of using the vaccine they have. If we had just said, well, we can't pay village malaria workers anymore, I think we would not be where we are today. But because we were able to think nimbly and figure out new ways of working, this network is now a dramatic success. Case management, I would argue, does three things, right? It obviously just cures people so that they don't get severe disease. It does drive down transmission, as I showed in my kind of simple cartoon model at the beginning. This is some data from Myanmar, from the Mahidol Institute there. And they're doing mass drug administration in this study. But what I find most fascinating is the top graph. They set up health posts that would monitor fevers and positivity over time so that they could see the effect of the MDAs they were doing. And accidentally, after they set up those health posts providing curative treatment for falciparum, they eliminated malaria in the places where they weren't doing MDA. Now, those were low incidence settings. So we've done some modeling work with Swiss TPH, who are our modeling partners on a lot of these activities. And it basically just confirms, this is really an Africa focused paper, but in these kind of low endemic settings, if all we do is make sure more people get diagnosed and treated, we do drive down that average durability of infection, and we can drive elimination through those sorts of pretty, I shouldn't say easy, but sustainable kinds of approaches that don't involve going out and doing a big campaign at high cost. The other thing that case management gives us is information. With that massive increase in testing, we can now see across the country, and because we have that surveillance system in place where everything is mapped, we can now see where malaria transmission is happening. And increasingly, cases are classified as to whether people have been moving, and we can trace them back to which forests we think they were infected in or which country they came from. And what that lets us do is then make sure we're using our other tools in a more effective way. Right. And so here's Laos again. If we're looking at Southern Laos, reported cases at district level, we had 916,000 people who were in need of bed nets because per policy, they lived in the highest endemic areas. And we worked with the Malaria Atlas Project, which if you're not familiar, they're based out in Perth, which I didn't realize how far it was. Australia is quite a large country. But they are at Curtin University and the Kids Research Institute, and they are world experts in geospatial epidemiology. And so we have a standing partnership with them where they create really high resolution maps. They can ingest incidence data and prevalence data and put it through all these covariates and get these lovely maps. And when we did this kind of work for the BedNet campaign in Laos, we found that there was actually about 30% fewer people living in the highest risk areas and thus did not distribute nets to those people. We could move that money and have a bigger impact elsewhere. So here are the case histories. These are only confirmed cases. I kind of wish I had put the unconfirmed in Laos on the map because it was at 100,000 probably back in 2000. But this, to our best of our knowledge, are true malaria cases. And you can see sort of at the tail end these big reductions, including in Myanmar, this is the only Myanmar slide I'll get to, unfortunately, up until the point of the military coup. And it's a reminder that elimination requires stability. It's not impossible to do well. Sri Lanka is a famous example where they did eliminate despite having an incredibly bloody civil war, but it sure makes elimination much, much harder to do. And if I put these graphs on the log scale, the way that I showed with that earlier one, you can really see the breakpoints, particularly sharp in Cambodia, where following the diagnosis and treatment scale up, following the beginning of using analytical information to place our tools in the right places, we've just been on this steep decline to zero. And again, we have gone about a year now without any falciparum cases, and Laos is not far behind. This is only falciparum now. The donors are very focused on falciparum because those are the strains that have the resistance to the ACTs. We would like to eliminate all of the malaria from the region and maybe some other pathogens while we're at it. But we will need to continue at minimum for a few more years to clear out falciparum from the region. And of course, the problem with that is that we might not have a few more years. You've all seen the headlines. The US government is the single biggest donor to malaria control and elimination globally, both bilaterally through the US President's Malaria Initiative and through the Global Fund. This is true for many other diseases as well. And the US is not alone. Many other countries are now cutting back their financing. We are waiting to see the implications for the Global Fund, which has been the major financing mechanism by which all of this has happened. But reductions are not our friend because we have to continue these ecological changes long enough to get to zero. If we stop now, that will not hold. There is no gravity here driving malaria to zero. We can expect resurgence, and we have seen it before in the history of malaria. So I just wanted to end with a couple of slides on some of our NTD work. And the hypothesis we had when we started doing any kind of neglected tropical disease work was that this approach that we've been building for malaria elimination specifically should be fully applicable to NTDs. They're going out and doing these big mass drug administration campaigns. And yet the data are not always of the quality they could be. We're not always targeting as well as we can. They're based on survey data only done so often. So just a couple anecdotes that I think to me do validate the hypothesis that there's a ton more we could be doing in this space. And the first is an example from Nigeria, where they go out and do a mass drug administration campaign for schisto and soil transmitted helminths in schools specifically. And the short story is the school list was wildly incomplete. They had a formal list of schools that did not include informal schools, which are largely religious Islamic schools in the state of Nigeria. And that meant 1.4 million children were not even being targeted for the MDA. So if you're starting from inaccurate information, you're going to end up with low coverage. No matter what you think you're measuring, in fact, you're not doing the job. And very similar story in Burkina Faso, where we helped to digitize this campaign for lymphatic filariasis. The program had done over 20 rounds of MDA year after year, always meeting their coverage targets, and yet they weren't seeing elimination happen. And you can understand why when you see that all these orange points, I don't know if the color comes through, have over 100% coverage and some over 200% coverage. And if you've worked with data where you find 150% coverage, you can either be very pleased with yourself or say, oh no, what have I done? And so digitizing the campaign, making sure that when the worker goes out and gives the drugs, that we are actually getting digital records of that child got a drug in this place with a geo-coordinate, it allows us to measure what we're doing really well. The upshot is that coverage went down, right? And nobody's happy to see coverage goes down, but it means that now we are actually beginning to measure what we're really doing rather than this kind of made up number that does not help us to manage ourselves appropriately. So I'm going to leave it there. I mean, I think the Mekong to me is an astonishing story. I hope it's a story that we will have the opportunity to help governments finish. It is a story of how these breakpoints can be real, that we can, through proactive measures, change these kind of background trends and drive malaria and other diseases to zero. And I think this approach of shortening infection durations, blocking transmission, and building all of that on the back of really strong surveillance, it's not a malaria story, right? This is relevant for any elimination program, for any public health program, I would argue. And so I've learned a lot from the experience of the Mekong and working with the programs there. And I'm very pleased to have had the opportunity to share some of this with you today. Thank you so much, and we'd love to take any questions.
No, we are now open for questions, both in the room and online. We have a surprise first question from Jason.
Just awesome, like really fascinating presentation. Thanks so much. I'm just sort of curious in terms.
Just introduce yourself.
Oh, Jason Grebley from the Kirby Institute. I'm just really interested in your discussions with partners and donors, given sort of the withdrawal of funding. Are you seeing anything in terms of global philanthropic donors stepping in at all? And so that's, I guess, question one. And then question two is just curious on your thoughts around what do you think this is going to mean for the sort of global fund replenishment bid Just any insights just from talking to people?
Yeah, go ahead.
Yeah, I mean, I think in the early going, there was a lot of talk about moral hazard, right? If a philanthropic donor, if Bill Gates says, I will step in and cover the things that the US government were doing, which he could not, for the record, right? The governments have so much money to put towards these things. So there was some fear that if they were to do that, that would basically give the US, for example, carte blanche to not come back. And so I think everyone is still a little bit tentative about doing it, but we certainly have seen a number of donors who are rising to that occasion and who are evaluating what is it that we can do in this space. Some of the ones we work with come from the effective altruism community, and GiveWell is a really interesting donor who tries to do the most cost-effective investment of donor money that they can. And they've really stepped up, in particular, funding some of the planning stages for seasonal malaria chemo prevention in sub-Saharan Africa. These are seasonal campaigns that all have to start by June, basically, because that's when the rains are going to come. And if the campaign doesn't happen on time, kids are going to get infected. And so we're providing chemo prevention in that case. And so they stepped up to begin providing philanthropic money to allow programs to keep moving forward. And now it seems likely that the US government has figured out mechanisms to then actually fund the distribution. And so by having that philanthropic donor buy time, I think we'll be able to get most of those campaigns off this year. And I think we'll see more of that going forward as the dust settles a little bit and we know what the US government is committed to doing over the next few years and is not, because it does still seem like there will be money for malaria. There in the budget that was shared by the White House, there was money for the Global Fund as well. It just seemed like we were looking at about a 50% haircut across the boards, which is devastating, but certainly better than not having any malaria, any money for malaria and for other diseases. In terms of the Global Fund, you know, I don't want to speak on their behalf. I do not have inside information about what their financials look like, but simply looking at publicly available information, which suggests the US is about a third of all the money going to the Global Fund. We can all do the math of what a 50% cut on a third of the Global Fund would look like. And we've seen the announcements from the UK that their contributions will go down. And so I think there is reason to believe that we are looking at much smaller allocations going forward. And we'll all just have to continue to be advocates to the extent we can for pushing to keep those allocations as high as we can.
Greg?
Great talk, Justin. Great to see that you're going for true epidemiological elimination. I mean, we work in HIV and viral hepatitis that use global elimination targets, which are really infectious disease control targets rather than epidemiological elimination. So just be nice to get your thoughts on that strategic sort of use of elimination in the context of HIV and viral hepatitis versus obviously very different infections, decades of infection, no vector involved versus months and vector. But do you think it's a good thing that HIV and viral hep are using elimination as their global sort of banner in terms of infectious disease control?
It's a great question. And of course, from the NTD side, we have exactly the same, right? Elimination is a public health problem. No two diseases seem to have the same elimination endpoint. I wrote a paper about the definition of elimination. If you go back into my my malaria journal publication, so it is something that I have always felt a bit passionately about. Is not necessarily exactly the right way to go. I think we need to be clear in what we're trying to achieve, and I think people will understand us if we explain what we're trying to do. The thing that is very clear to me, having worked with programs in so many countries, is that we need very clear goals. Elimination, however one understands it, seems to be clear because it means we are getting rid of something, right? And as I said, we can measure if we've done that or not. This disease is still here, it is not here. And that to me is both the advantage of elimination and the risk in using the term loosely. If we say we've eliminated something, and I think the same would be true of only eliminating falciparum from the Mekong. If people are still getting sick with malaria, they would say, why are you celebrating? What have you done, right? And I think, you know, the US eliminated measles years ago, and yet we are in the midst of an enormous measles outbreak. I think these are confusing terms. I think, yeah, definitely merit in setting very clear goals, explaining how we're going to measure those goals and helping everyone work towards them. But I, you know, personally would maybe choose some different words that mean different things.
Yeah, I think the issue often arises that they have this magic number you've got to reach, and as soon if you're just below that, well, we're done, and you might be just above it. Susanna Vajneri.
Thanks, Susanna Vajneri, Kirby Institute. Thanks, great presentation, and brings me back to my malaria times. I'm not sure if these are questions or a bit sort of kind of provocative thoughts. Maybe I'd like to kind of hear a bit more about two things you mentioned. One is this market shaper sort of approach. I was interested in, like for instance, with bed nets for malaria, I mean, somebody's paying for the bed nets, obviously, because they are not free to make. But I guess in countries kind of scaling up bed nets distribution, there was, at least 10 years ago, some debate on whether bed nets should be free, or there were also kind of in the world of NGOs and bilateral, some I guess ideological differences where some NGOs were actually pushing countries to create a market for selling bed nets. So I guess my question is around that, sort of like how CHAI goes around, because a lot of these goods can be seen as public health goods and they should be free and people shouldn't have to pay for them, versus the market approach of making things accessible for people to buy them, which is, I guess, ideology maybe more aligned with the US, I guess. Sorry, but it is. And then I guess similarly with the last example in terms of with this global fund, strings attached kind of funding, where they said that, I guess if I understood correctly, that there would not be cash rewards. And basically, I'm not saying it was bad to help the country move to electronic transfers, but I guess that's a big intervention in terms of the economy of a country. And to the extent, I guess I always try to reflect on the extent that donors should be pushing for those things when they are doing development programs. Sorry for the provocation.
No, thank you. No, I think it's really important. And I think it's particularly important as we enter a more resource constrained time. We need to have some of these debates again. I mean, in the early days of malaria bed nets, absolutely people worked on market interventions. In Tanzania, there was an effort to build the market there. Poorest people could get vouchers. Prices were negotiated, and the idea was we're creating a healthy ecosystem by which bed nets will be available to people and people will be able to access them. That all changed when the Global Fund and PMI and the other big donors started buying bed nets at these massive scales and distributing them. And of course, those markets struggled to compete with free bed nets. I will say they still exist. If you look across DHS surveys, RIP, you will find that about, I think, 15% of bed nets that you find out in people's houses were purchased. Now, some of them may be not the insecticidal nets we want. They might be of poorer quality, but that does suggest these two things can actually live together harmoniously. I believe that we cannot afford to continue doing campaigns where we distribute nets to everyone in the country, and that we should be focusing, as per the surveillance data, on places where people are too poor to buy it, where the private sector is simply not a viable option, or where we can't provide quality services that way. So I think those campaigns, those free tools, they have a place. But to ignore the fact that the private sector is there, in Nigeria, if we look at malaria treatment, over half of malaria treatment is happening in drug shops, often just the drug shop on the corner. You go to the store and you buy some drugs and you take those drugs. We can ignore that, or we can try to figure out how do we leverage that opportunity to provide good quality case management instead of bad. And so we worked in those settings to subsidize the price of really good quality drugs and let them go through the same channels. So with no need for the government to hire workers and go out and distribute them, we found we were getting high quality ACTs all over rural sub-Saharan Africa through these top of the supply chain market mechanisms. Yes, please. Sorry. And just to say on the village malaria workers, that wasn't a change. They were always being paid in that setting. They were a professional cadre, because I think it's fair to say if you don't pay people, there's only so much you can ask of them. So whether to pay community health workers is a lengthy debate that we probably don't have time for now. It does come with the need to make this a professional cadre and have the budget that is required to do that.
We've got just 3 more minutes, but I hope not too many people have to disappear, and maybe can just give us another couple of extra minutes. We have a couple of quick questions here, and also we have one online. We have a question about whether AI could be useful to detect patterns of malaria in some of the models that you've suggested. But maybe I'll just ask if you could make a question quick, and we'll get.
Yeah, just a quick question. Great presentation. I'm Paolo Bareng, Kirby Institute. I know you mentioned it briefly, but I know there's a trend of increasing Plasmodium vivax cases and declining falciparum, especially in that in Greater Mekong regions. How do you address these increasing Plasmodium vivax cases, especially that most interventions are targeting for sleeper malaria, and they're not necessarily effective against vivax? So
Thank you.
And why don't you ask while you're there, and then we can.
Thanks.
wrap up the answer.
Hi, I'm Virginia Wiseman. I just wondered whether CHI get involved in more health system strengthening interventions. So I'm thinking particularly of two things. One is helping countries, especially at the moment, with contracting out to community providers, NGOs and others to deliver services, which is a really big challenge, has always been, but is even perhaps more so now. And then secondly, the role with working with private sector. So a lot of the interventions that we've talked about, even the voucher, I mean, I was involved in the evaluation of the national ITN scale up in Tanzania. I mean, private providers were integral to that. So a lot of the interventions are public, but I wanted to hear a bit more about the private engagement with the private sector. Thanks.
Thank you. AI, I'd say too early to say. I hope it's going to be a powerful tool for us. We didn't really get into the mathematical modeling, but I think if you're a mathematical modeler, there clearly are potential implications. The one place we do use machine learning are in those Malaria Atlas Project maps. That is a machine learning. It's a type of AI, I would argue. And so, yeah, I mean, we've already seen the power of it. And as we get better tools for finding patterns, I'm sure we'll be able to deploy them. Vivax, it's a great question. We didn't really get into it. The mosquito side's the same, right? If you kill the mosquito, it doesn't transmit either, but the drug side is different. Vivax can be dormant in your liver. That's not your liver. I'm not a clinician. And so you need a radical cure drug. The one we use is called Primaquine. It's quite toxic, and so we space it out over many days. There is a version called Tefenaquine that's one dose, and the issues have been that Primaquine doesn't have great adherence because you can take it for 14 days in a row, which people don't necessarily adhere to. But Tefenaquine, although it's one dose, can be toxic to people with a certain genetic condition. And so then we have to add G6PD deficiency testing, which is a layer of complication, but it is happening. And so we are getting Vivax radical cure across most all the countries we support. I think maybe not Myanmar. And so that's really exciting. And we are seeing Vivax being driven down as well as a result. The private sector, yeah, I mean, as we mentioned, I personally am a huge believer. We have a private sector subsidy happening now in Nigeria for malaria drugs. For bed nets, I think it's been very underexplored in the last 15, 20 years. And so I do think there's a need to get back to thinking about what the private sector can provide. We also have routine distribution of nets through schools, through ANC, through EPI clinics. And although there is a lot of money in the Global Fund grants to do that, because it's not run by a malaria program, it's run by EPI or ANC, the visibility as to whether it's working well is really not there for malaria programs. And so to your first question, yes, we have to start thinking about this in a much more health systems way. I need to stop being a malaria professional and someone that works on primary healthcare, on getting access to good quality drugs to little kids who need it. And so if we're not building our systems in that way going forward, I think we're missing the opportunity that this disruption to global health presents. If we continue to have 30% overheads on contracts that go out to distribute bed nets, I think we are missing an opportunity to use our resources more effectively. And I hope that in the years to come, we'll find much more government-owned, much more integrated systems that are ultimately going to be more resilient, more sustainable, and more successful.
And the question I had saved up, which I won't ask Justin to respond to, which is how to, there's amazing work that they're doing primarily with governments, but these countries also have academic institutions which could really benefit from both capacity building and to enhance the sustainability. And how does CHI work in a way that can also enhance and bring in and develop the academic research capacity? And maybe that's what we can talk about more this afternoon. But please join me in thanking Justin for a fantastic presentation.